Effects of chlorhexidine baths for patients with central lines. Hi, I'm Danielle. Welcome to my presentation on effects of chlorhexidine baths for patients with central lines. I'm currently an ICU nurse at Honor Health Deer Valley, where I encounter patients who have some sort of central line access or arterial access. Doing my part to keep my patients safe, mitigate further illness, and give my patients the best outcomes is very important to me, which is why I selected this topic. Chlorhexidine baths, also known as CHG baths, are considered an effective tool in reducing incidences of CLABSI in relation to traditional bed baths and even when compared to other preventative tools such as octreotide. Even though octreotide and chlorhexidine share similar compounds, chlorhexidine was still shown to have better outcomes on reducing the incidences of CLABSI. Some hospitals actually have requirements for patients with central lines to receive a CHG bath. It is a task that often goes undone because it's viewed as less important, so oftentimes nurses will kind of push it to the bottom of their priority list, and then it ends up not being done. So, in patients with central line access, how do chlorhexidine baths compared to no chlorhexidine baths affect infection rates? Let's dive into the research and find out. First, let's discuss how we actually selected the articles that were used to discover the evidence for the effects of chlorhexidine baths versus no chlorhexidine baths. Using databases CINAHL, PubMed, and Elsevier, I used search terms such as inpatient, hospitalized patients, CHG wipes, CHG bath, chlorhexidine, CLABSI, infection rates, and central line infection. Initially, my search resulted in 1,141 articles. To get that number narrowed down, I input specific inclusion criteria to populate data from the last 5 years. I wanted to make sure that these were peer-reviewed in full text and only in English language. This still gave me 121 articles, so I skimmed through and selected 18 articles that were relevant to what I specifically was looking for this research. I ended up excluding articles that had information on whether using chlorhexidine in locking devices for dialysis supports were more effective versus, I think it was alcohol. There were also some articles that were establishing whether CHG gel or CHG sponge dressings were more effective, or looking at the cost of using CHG baths versus having to pay out for patients who did end up with some sort of CLABSI or infection, and have what the cost was to treat those infections. So of the 18 articles that were screened, 5 were assessed, and that's what was selected and used for the bulk of this presentation. The data did show there was a significant correlation of decreased incidence of CLABSI with adherence to daily CHG bathing. So moving forward will be a policy implemented to make CHG baths a requirement on every unit. The model for implementing this intervention will be based on practice guidelines. Following this model, we will optimize patient care using evidence-based practice and clinical decision-making when implementing these changes. The practice guideline will be provided in the form of a newsletter. These will be sent out each week for a month so that staff are notified about the change. Then they'll receive education modules and a demonstration on the floor by the unit's educator. Education included in the modules will have information on the effects of CHG bathing, as well as information on the elements within the CHG wipes that make them effective. Once the modules are complete, a demonstration of this skill will be done on each unit, and then everyone will require to be checked off for this skill. Educating the nursing staff on the effects of CHG baths and their importance, we hope to change the attitudes of the nursing staff to have them recognize this as an important task and not allow it to go overlooked and undone. Nurse attitudes on how important CHG bathing was shown to be a reason for the task not being completed and a lack of compliance with charting in the EMR. Now, bringing it all together for our comprehensive plan aimed at reducing the incidence of central line associated bloodstream infections, also known as CLABSI, in our non-ICU units. Our primary goal is to reduce the incidence of CLABSI from 1.4 per 1,000 catheter days to 0.7 per 1,000 catheter days. This initiative is critical as CLABSI significantly impacts patient outcomes and increases healthcare costs. Our project team will be led by our unit educators. Each unit will appoint a champion who will help with auditing and collecting data. These champions can be nurses or UAPs, unlicensed assistive personnel. As long as they provide direct patient care. Their role will be critical in ensuring adherence to our new protocols, supporting their colleagues, and assisting with the data collection. To understand where we're starting from, we have collected data on CLABSI incidents in our non-ICU units over the last 12 months. Our gap analysis identified issues such as staff attitudes, lack of knowledge on how to effectively provide a CHG bath. These steps are really critical in preventing CLABSI. First, we will provide notice of the change through newsletters. These will be sent out each week for a month. Then education modules and training and skill demonstrations to enhance any current knowledge or skill. We'll also standardize protocols by developing EPIC banners that remind the nurses and UAPs to provide the CHG baths for those specific patients. Compliance will be enhanced through weekly audits of the EMR documentation, and we'll conduct daily audits to assess the necessity of the central line access. We want to encourage prompt removal of unnecessary lines. In addition, we will be implementing a CLABSI prevention team, assigning 2 to 3 nurses or UAPs per shift to complete the CHG baths for that unit. Our implementation plan includes a timeline where a newsletter will be distributed to kick off the project, educators providing demonstrations of the proper CHG baths, where all nurses and all nursing staff is going to be required to sign an accountability sheet to confirm they've received that education and have been checked off on that skill. The resource allocation includes time for creating the newsletter, educators' time for demonstrations, the cost of CHG costs as well. And after all of this education has been provided, we will begin our data collection, reviewing CLABSI incidents every 3 months after the implementation. And performance metrics will include compliance with the EMR and completion of the CHG baths. Feedback mechanisms are going to be sent out in the form of surveys so that we can assess what the impact has been on the staff, as well as to identify areas where we can make improvement of this intervention. To ensure we are able to sustain this implementation, we'll provide ongoing training through annual newsletters or annual education modules that have to be completed. We want to be able to implement this into the hospital policies and standard operating procedures in order to continue improving the CLABSI prevention interventions. We'll also require the CLABSI prevention interventions to be in all onboarding packets. So the communication plan is to send internal communication, quarterly updates to unit champions and stakeholders on our project progress and outcomes. And then externally, we want to share our success rates with other hospitals or healthcare institutions who have central line patients so that we can broaden the improvements in patient care and patient safety. In order to establish a baseline for the effectiveness of our implemented intervention, data on CLABSI over the previous 12 months will be collected. We'll compare our numbers to this baseline number to see how much improvement we've had. Once the education has concluded, the full implementation process will begin. So each week, chart audits will be done by our unit champions. And then every 3 months, the total data of the incidence of CLABSI will be collected and compared against our previous CLABSI results from the last 12 months. This will tell us how effective our implementation has been. This will tell us the effectiveness of our intervention that we've implemented. So do I think my PICO question was answered, and why? In the short, yes, I believe my PICO question was answered. I was able to find several peer-reviewed published articles that were within the last 5 years explaining exactly what the effects of chlorhexidine baths are on patients with central line access. I read an article that stated that there was not a significant incidence of CLABSI in a particular hospital, but they still saw an improvement on the incidences of CLABSI. There was another article that discussed that even though there was not a statistical significance, there was a clinical significance in the reduction of CLABSI. The articles were very specific in discussing that CHG baths do need to be done daily, like the adherence needs to be daily, and they need to be done correctly. They need to be completed where the dressing is actually part of the bathing process, so that chlorhexidine is protecting that area on and around the dressing as well. So yes, I do think that my PICO question was answered very thoroughly with a lot of really good data. I just want to thank all the researchers for their data and for all their hard work creating evidence-based guidelines for us frontline bedside healthcare workers so that we can provide the best patient outcomes.